A 72-year-old male with a history of frequency, urgency, actually associated post-treatment study for the past 2 years.
I would.
It didn't be history of constipation.
Oh, I would like to know since 2 years whether he was on any medication or whether any history of previous UTIs or since 2 years, since his fluid intake is high, 4 to 4.5 liters, I would also like to know about the warding daily of that patient actually. The previous, this one.
He is on hypertension for the past 10 years and ASD for 3 years with the following medications. He had one episode of UTI around 6 months back. No other significant contribution.
Okay. Since he had a pain and he was catheterized, whether he was catheterized after this USC since pain and inability to void. If catheterized, I would like to know how much amount of the urine was drained and subsequently.
He presented to us like this only. He was not catheterized.
No, complaining of pain abdomen and inability to void.
Nothing was done. He came like this to the emergency ward.
Yeah.
After that, he voided.
After that,
he went into retention while doing while waiting for the USG.
Correct.
Yeah. After that, what was the intervention done for that same? Means inability.
And this is the point at which the patient presented.
Okay.
Here we have to discuss.
So basically, he had history for the past 2 years. Now he presented with history of pain abdomen and inability to void following the recent USG.
Yeah, because this is 72-year-old male with the previous LUTs and presenting with probably acute urinary retention on alpha block while while undergoing a USG test actually. I would like to know whether they told.
So based on the initial history, what is the provisional diagnosis?
Considering age, the most common will be a BEP, so benign enlargement of prostate, followed by most probably complication of UTI, means BEP, like vesical cal may be present, vesical calculus, and the third may be because considering his age, CA prostate can be considered.
Anything else?
Since
So why do you think the patient presented now with suspended retention? He was on alpha blocker for the past 2 to 3 years.
Yes, so he was having voiding blood since 1.5 years and was on alpha blockers, and now because of the over-distension of the bladder, it may precipitate the acute urinary retention while waiting for the USC, possibly yes, because he is sticking around.
Okay, what are the other causes for respiratory retention?
Urinary tract UTI, urinary tract infections, or it may be spontaneous or precipitated. So spontaneous can be anytime. Precipitated, there are various causes like UTI, this over distension of bladder, and
Anything else?
Any medications also, sir, taking?
What kind of medications?
Anticholinergics, sir.
Why do you think the 100-year-old will take anticholinergics? For what reason?
Means he might be taking for overactive symptoms, or if at all he might be having the log associated with it. It may precipitate.
That is not mentioned here, no? It's only because for any other non-urological conditions. It can be any drug which has an anticonvulsive effect. Right?
Yes, sir.
Can any psychiatric medications, anxiety medications cause this problem?
SSRI, sir, most common will be SSRI.
That is not necessarily, not commonly used.
Sir, I didn't get.
Commonly used drug. Usually, everyone gives it for depression, night depression.
I don't know, sir.
Any other drugs, any other factors which cause respiratory tension. What is the cause for spontaneous retention? In the age?
Spontaneous. There is no, sir. It may be because of the large median lobe, sir, but spontaneous doesn't has any like etiologies.
Yeah, large median lobe only, but how does it cause retention suddenly? First of all, is it acute retention or chronic retention?
Since he has a pain during a retention, it may, since it is associated with pain and inability to void, probably it is acute retention.
Okay, so what might be the cause in a deep age, a median lobe, suddenly went into retention?
Like maybe due to the prostatic infarct causing edema and causing acute retention, especially in large prostate.
Prostatic ischemia, prostate.
A prostatic infarct. Basically, prostate outgrows the blood supply, and at some point, some of the tissues may become ischemic and infarct, and then edema and retention.
Yes, sir.
So, any other bowel factors which can cause retention, respiratory retention?
Most is constipation, so bowel bladder dysfunction.
So, in which case this is common, this bowel causing retention of urine.
Yes. Mainly because of constipation, they might have the retention.
Bladder bowel dysfunction causing retention.
And that is
In what age groups it is commonly seen?
younger in the children, sir, actually, more.
Children and elderly also. So what else is the you have anything else in the diagnosis, differential diagnosis?
Sir?
Anything extra in differential diagnosis? Apart from what you told?
No, sir.
Can it be stricture etc.?
Number 207.
He's taking.
Number 207. Code origin second number 207.
But he has the frequency and intermittency, sir, which is like, and it's on alpha blockers. Probably, if at all taking alpha blockers, then possibly points towards the prostate rather than the stricture urethra. And there is no previous urological intervention also.
Okay. What do you want?
I would like to know since he had a pain and inability to void, whether what was done for that patient, and subsequently, if at all catheterized, what was the amount drained, amount of the urine drained, and examination ECOG 0. Other than BP 145 by 67, other parameters are normal, sir. And DRE shows grade 3 prostate, which is firm and non-tender, and inner tone is normal. Bladder till umbilicus. Yes, sir. For abdomen, hemoglobin is 15.9. Creatinine is elevated, so with a 2.18 milligram per day. Normal. Urine routine is normal, sir, actually. So I would like to know, have the USG ultrasound to see the upper tract changes, actually, whether there had any hydroator nephrosis, or and also would like to know the prostate size. And
you only told patient came in acute painful retention, so you don't want to relieve retention, you want to go for ultrasound.
no, so I asked whether he was catheterized, but they told it was. But I asked how much.
He presented to us like this, that we have examined and this is the finding. So what we will do, this is the exam now, that's why we have given a case of acute urinary retention. How we will proceed with that?
I will first catheterize the patient, sir, since he is in pain and inability to work. And since creatinine is elevated, further we would like to investigate further.
So we have categorized in 600 ml of clear uric pulse, drained as tap out.
Okay.
Is that important?
Yes, sir. If the urine drained was very large, then probably it will point towards underactive bladder or underactive bladder. It will be greater than 600 or, and it may require further investigations with the urodynamics.
Will it affect your management? The volume drain, does it affect your management decisions?
Yes, sir. If it's too large, then if it's underactive bladder, we may not do the TURP, and again after urodynamics, if the P date is less, then we may advise him to go for CIC, because since he is on the long-term alpha blockers, the compliance might have also been affected.
So your understanding of bladder outlet obstruction is that when a patient comes with acute painful retention, you want to rule out underactive bladder. Is that correct?
No, sir. If it is in the acute urinary retention, then there's no need of urodynamics, sir. If
so
it
now I will ask you the question again. This patient has come with acute painful retention.
Yes,
and
sir.
You have drained 600 ml on catheterization. How will it affect your management decision?
No, sir. Here, since serum creatinine is elevated and probably some upper tract changes, the volume drain might not affect this one, because since bladder outlet obstruction is already present, we may go for a surgical intervention.
Okay, agreed.
So, USG of.
Okay, we'll stick to this image.
Okay, sir. This ultrasound of the prostate, so probably the prostate showing the prostate volume of around 89 cc with a median lobe, with the median lobe and intravesical protrusion of the prostate. The length of the intravesical protrusion is not mentioned, sir.
Very good. Yeah, go ahead.
And probably bladder. Bladder, I can't comment. Sir. Bladder, the bladder is distended with wall, probably wall thickness. I don't know.
I'll give you the length, width, and the breadth of the prostate. How do you measure the volume? You know the formula of measure.
Sir?
The prostate length, width, and the height. I'll give you the 3 dimensions. How do you use? They've written volume over there 89, right? So how do they calculate the volume? You know the formula for that?
It's 2 by 3rd of all the 3 multipliers. Height, weight, and length, and possibly 0.5 or 0.5 times the height, width, and length. Sir.
You've given us 3 formulas. T1 into T2 into T3 divided by what? Don't know. Okay, go ahead.
No.
So in this case only, the start output is 600 ml acute retention. The patient is not having renal failure. Not having failure. So, trial wide to him or what? Basically, they want to know what are the factors which indicate that this patient will fail a trial wide.
So in this patient, the median lobe is large. So the medical therapy may fail.
No. So you have to tell us all the factors. Is 600 ml a contraindication to trial void?
No, sir.
No. Agreed. What volume would you not give a trial void?
If it's greater than means if it's large amount of urine drained, 1000 ml or something like that, then I would not give a trial void, sir.
So please remember, in the exam you cannot sit on the fence. You cannot say 1000 ml or something like that. I may, I should, no. If it is more than a liter, I will not give a trial void. You say 900 ml, you say 1 liter, that doesn't really matter. Stand your ground.
Yes, sir.
Okay, volume range. Then what else? You mentioned something is not being measured.
And if he was in painless retention, sir, actually
No. Let's stick to painful retention. Here on the ultrasound, what other features would you want?
if your upper tract changes are there with bilateral hydroreturn nephrosis, I would not like to give a trial void. And with the elevated serum creatinine.
No, so Vinod's question was, let us assume that the upper tracts are normal. He's come in acute painful retention. You have this ultrasound in front of you. 600 ml has been drained. What are the other factors which will tell you, I will not give a trial void in this case? Let me make it easier for you.
If a patient has a previous history of acute urinary retentions, previous history of UTI, and
So, Amraj, you are telling us the absolute indications for surgery. We don't want that. We want, how do you decide should we give trial void or we should not give trial void when the absolute indications for surgery do not exist?
You understand the question, no? The absolute indications for surgery are those 5 which are listed. He wants to know, apart from that situation, when will you not give trial voiding in a patient with acute?
Okay, is Sambhaji over there?
Who?
Sambhaji, sir. I'm just asking a question to somebody else. Or Kamal. Are you there?
Yes, sir, we are there. Good morning, sir.
Okay, so answer the question, please.
Sir, upper tract changes, sir, renal dysfunction. Sir, because of that, I will not give.
Stop. Vinod, I think you only tell them what you want. Okay, Praveen, have it. No. Okay, Vinod. This is basically any acute indications for surgery and upper tract changes are all we know that patient needs surgery. The patient coming fresh first time with acute painful retention, if the age is more than 70 years, if the prostate size is more than 50 grams, if there is a median lobe more than 2.5 centimeters, and stat output of more than 1000 ml, these are the factors which say that this patient is going to fail a trial ward and will need surgery. So in such a patient, directly you can go ahead with URP, explaining that there is a chance of failure of trial ward.
Is that okay, Kamraj?
It's Harish actually on the seat, hot seat today. Actually, before all this drama started with drugs and all that, none of this was there. A patient came with acute retention. If there was no other precipitating cause, he would have his TURP done the next day, and nobody regretted. This much I'll tell you. Nobody regretted TURP when it was done. Mark what I said. No other reason. No constipation, no this, no inebriated state, all that. Straight acute retention. He may or may never have had any history of bloods. Rectal exam, large prostate, retention, acute painful retention, TURP next day. I mean, you won't do it for a 25-year-old fellow. We are talking of the prostatic age group here. If you ask patients who have been in acute retention, they will tell you, I've never had problems. There will be a group of patients, never had any trouble passing. Suddenly it happened. Maybe it was a period of over distension or whatever it was. Something is triggered.
So to complete that answer, you have at the point which Sir said that you have to rule out precipitating causes and confirm that it is non-precipitated acute retention. Now, if I biopsy this prostate, if I take out the whole prostate and biopsy it, what will I find?
Fibroadenomatous hyperplasia.
Hyperplasia, okay, but what is the pathological finding which is usually there associated with acute retention?
So, what are the pathological link? Acute retention, you take this prostate out and you want to know what are the biopsy picture that you can see. What are all the findings that are likely to be there? Apart from what you said, is there anything else that you're likely to see in this prostate on HPE? You read so many biopsy reports of TURP specimen. They all say what final impression is there. But if you read the print of the biopsy micro, you'll understand.
Non-specific granulomatous.
Huh? Okay, there may be what?
Non-specific inflammation.
Non-specific inflammation. What do you mean by non-specific inflammation?
There may be
what else?
Maybe granulomatous or non-granulomatous.
Okay, there may be granulomatous prostatitis. There may be non-granulomatous prostatitis. What other prostatitis could there be? Acute retention.
Prostatic abscess, prostatic ischemia.
There may be some areas of prostatic abscess. Very good. Anything else it can have?
Prostatic ischemia.
Prostatic areas of, therefore, what will you see in that?
Necrosis.
You may see infarction. What else will you see? You may see chronic prostatitis, isn't it? There may be areas in the prostate which have got chronic prostatitis. There are so many findings in a patient who is likely to have retention. You take the prostate out. One more thing you can see also, you may find. What is it? Remember, Manish said, take out the whole prostate. Any takers? Malignancy, yes, absolutely. There may be a focus. Sometimes in TURP chips, don't you find some areas of advocacy? There may be. So, All these features are likely to be there in somebody who's had a prostate removed, even with acute prostatic, right? Carry on, sir.
So which study, name a group of studies or a study which defined all these parameters and is very famous? Anybody? Okay.
MDOT study,
It's
combined.
Okay, so please remember some of these studies and go and read the abstracts, and you need to know at least grossly what they have said.
yes, sir.
By the way, just to interject, you can get a case like this in the exam. BPH, straightforward BPH.
So my aim,
How many things are there on BPH that they will ask you on this? So it is a classical exam case, starting from pathophysiology, medical management, studies, treatment, laser, phaser, all that, newer treatments. So you can imagine just on BPH, acute retention, each candidate can be asked a different aspect, the same case. You don't have to be asked the same question every time. You can ask so many questions.
so my DNB exam, we had one BPH patient, 5 people examining him, and after all those 5, in order to confirm the findings, Dr. Kandasamy came and did his rectal also again. So this was the exact case, acute retention on Foley cap without. Okay, so now, how do you explain the renal failure? There was no hydronephrosis.
You have seen, no? Patient comes with acute retention, that day you do the creatinine. At all.
No upper tract changes. There is no upper tract changes in
No, he says there is no upper tract change. How do you explain renal failure in this patient?
probably associated with this comorbidities.
So you have to speak little louder. I don't think they can hear you. Even I can't hear you. Remember, in the exam, you got a mask and you got to be loud. Some fellows may say take out the mask. Some fellows say don't take out the mask. So you have to speak louder.
He is also hypertensive, sir. Probably
Okay, he is also hypertensive. Therefore,
maybe associated with the chronic kidney disease.
okay, his creatinine may be elevated because of other reasons. Medical renal disease. Considered. Any other reason? But remember, no hydronephrosis. No hydronephrosis.
Maybe associated with the UTI also, sir, along with the pyelonephritis.
He may have urinary tract infection. All right. Okay. Anything else? Come man, there are so many other reasons why somebody creatinine could be elevated in the presence of acute retention.
How do you treat pain?
With the diagnosis, if you are giving any NSAID, sir.
Okay, so drugs, possible drugs.
Drugs. So one is NSAIDs. Other is anything else? Any other drug? Any other drug? Very commonly used. And antibiotics used right, left, and center. No, he would have gone with something else. Got someone shot 2-3 shots of gentamicin, amikacin, mixture of both. You don't know what will happen in this country. So drugs are both analgesics as well as antibiotics, culprits. Anything else happens to a patient with acute retention if you ask them, if you observe carefully and taken a history from them. What is another feature which stands out? That can be responsible for elevated creatinine. You take the history carefully.
Reduction in the water. They may be less hydrated also, sir.
Hydrated, very good. Hydration. You see, you have not probably been well. You're not able to eat when you're not well, and you've got retention. You don't know, and you're trying to feed something. So dehydration is an important reason for somebody having elevated creatinine. So many reasons. Last but not least, the very fact that that the bladder is distended itself can raise the creatinine temporarily. Because the moment you catheterize such a patient, it all comes down to normal very quickly. So what is the intravesical pressure in acute retention? Supposing this fellow comes with acute retention now, and I do urodynamics, but what will be the pressure recorded inside the bladder?
Greater than 97.
Sorry?
120.
120. What, any other number? Anybody else? What will be the intravesical pressure when you do urodynamics in this fellow when he comes with detention? Anybody else wants to take that question?
So 40 and above.
What?
1.5 centimeter of water.
Okay, let me put it this way. Will it be high? Will it be normal? Will it be low? Only three are possible. What are they? Harish says height 120. Anybody else says any other number? Anybody else taking for anybody else supporting height?
It can be depending on the patient to patient, sir. It can be low also because bladder wall is thinned
Hey,
out.
Baba, I just asked you a straight question. Don't say depend and all that. Straight question, acute retention. Is the pressure low? Is the pressure normal? Is the pressure high? Only three variables are there, nothing more.
Low, sir.
Low.
Yes, sir.
Who's saying low?
Sir, Kamal.
Any other colleague of yours wants to support you or go against you? One will go against you.
Sir,
Right.
low, sir.
Low. Anybody else for normal?
So since that's the only option left, I'll take that.
Sorry?
That is the only option left, I'll take that. Normal.
Actually, the pressures are low. You would think that the pressure is very high. It's not. The actual pressure recorded in the bladder dam retention is actually low pressure. It's not surprising, isn't it? But easy to understand. That's because the bladder is distended and stretched. But when you want to do urodynamics and you want to prove that's not a distant acute retention, it's a normal pressure. It's a high pressure problem. That is when the pressure will be more than 60, 80, 100 like that. But generally speaking, this is okay. What is the widening pressure in the fetus? Widening pressure in the fetus. Fetus also pisses, no?
Yes,
What is the widening pressure in the fetus? Anybody, Mr. Kamal? Sir?
Yes, sir. Sir, in that child, sir, there is no coordination between the sphincter and the bladder.
So there is no pressure in it.
So it will be low only, sir, in children.
No.
The bladder muscle wall is not
Right.
well enough.
Anybody else? Any other reason? Any other number? Huh?
Just above the amniotic fluid pressure.
Above what? Ordinary?
Amniotic fluid pressure, sir.
Amniotic fluid pressure. Oh. That's something new I heard. You know what? Studies have been done in fetuses. The widening pressures are exceedingly high. They are as high as systolic blood pressures. And this is another reason why, apart from the kidneys being dysplastic in PUV, against that obstructed valve, high pressures are being generated more than what is necessary. Very high pressures. Okay. Right. Carry on, sir. So you see the ramifications, the questions that can happen just with some fellow having BPH, bladder, retention, where all the questions can go. And half the questions haven't still been asked. So another group, another candidate will be asked a totally different set of questions.
So let me take you on that other track. Which part of his brain do you think is working very actively right now? Other than brain center, where is what happens to this bladder sensation when it goes? Where does it go?
It's maturation reflex, sir. It is
I can't hear you.
pontine and subpontine center, sir.
Any more details you can give us?
There is a pontine maturation center, isn't it? Any idea where it is located in the pons?
Is there a lateral area? Is there a medial area? Is one activating? Is one inhibiting?
Coronary is closed. Coronary is closed. Coronary is closed.
Okay. So anyway, please go and read the physiology of micturition. It's important to understand a lot of things.
Does
Yes,
the
sir.
pons maturation center act independently, fire independently? Is it controlled or just on its own, it gives commands?
It's actually inhibited, sir. Actually, when there is a sensation from the bladder, then
So it is, if I take off somebody's cerebrum and everything, this pontine maturation center will.
it's regulated by the cortex also.
Yeah. It is. The brain still controls the maturation center. No? Right.
Okay, so please go back and read the physiology of micturition. The other important point which was discussed is that when you read a biopsy report or a radiology report, please read the whole report so that you know you are familiar with whatever the biopsy reports. So now you have this patient here with brain here. Now what do we do?
For this patient, I would like to do TR, sir.
When? When
Yes.
would you like to do? Sir said earlier they used to come today and operate tomorrow. So
Yes.
they can give consent for surgery very readily, remembering the pain. But in this patient, when would you like to do?
Since his creatinine was slightly elevated, sir, I would like to wait, if at all, if it settles down for around 3 weeks. If it is still persistently high, then it's possibly he has other disease, means other renal disease which is responsible for the elevated creatinine. If it reaches its normal value, then I can say that it was because of the
Okay, so the answer I wanted to hear was I will wait for the nadir creatinine and then I will plan my surgery.
Yes, sir.
Okay, I have two options, either a URP or open surgery. I have just passed my MCH and gone to a small town. I'm not confident of doing an 89 grams plan. So between TURP and open, is there any other option other than these two?
Now, HOLEP is
No, I've gone to a small town and just passed my MCH. I do not have access to any of the fancy instruments. It's either TURP or open. So in between, is there a via media that we can plan? I don't want to open and I can't do a TURP for 89 grams at one go.
we have to put him on SPC or continuous catheter drainage.
Okay, so the answer is a hemi-TURP or a staged TURP is also an option which you must not forget.
Yes, sir.
Now,
Is there any other option apart from stage TURP and open prostate? Is there any other option? You have given me two options.
Yes, sir.
TURP and
open.
open. In that open, you know open. But in that stage, is there any variety of stage? Sub-classification. Staged is what? You have a large prostate, time running out, you do one side. And then after 2 days, you go back and do the other side. That is staged. Is there any other variety? Sub-classification. Any other way you can tackle a large prostate without doing open, but still doing TUR, but not staged?
Bypass.
No. What is the technique?
Yes, sir.
Hemiprostatectomy. All right? Just remove one lobe and leave it. Okay? Nice article reported from India itself. And I have personal experience. Patient was old. One said, okay, let us try what happens passing here. He's passing urine. Brings us to the question as to still today, nobody knows how much of prostate you must resect to ensure that he is passing urine. That is why the true test of prostatectomy is when you do a prostatectomy for acute retention and not when you do it for LUTs. In a patient with simple LUTs, he is passing urine. So even if you scratch it there, he will continue to pass urine. But if a fellow with acute retention comes and you don't do a good job, he'll be in trouble.
So there is also one paper where for the very elderly and sick patients, they've done only median lobe resection and those are also avoided.
Absolutely. In fact, Katie Fu is one of those people who has championed the cause of just medial lobe resection. He had a group of young Chinese who wanted ejaculation, who wanted to preserve their sexual function and all the ejaculation and everything. So he did only just the medial lobe. He would not resect anything else. He's given nice videos. Katie Fu was the chief of urology in Singapore, and quite a well-known man. So he has described this. And he is one of the architects of this IPP, intra-protrusion of the length of the prostate. 1 centimeter, 2, 3, he described this. And he correlated this with urodynamics. That is the important thing. Correlated this with urodynamic findings to say that that is why they say the medial lobe is very important. This whole theory, ball valve, true. Ball valve was, when general surgery and MBBS, they said medial lobe is like a ball valve, we said, probably true. So this is very important, this IPP measurements.
So Harish, if it is not important to take out a whole prostate, why do we insist that you come all the way up to the capsule and treat?
So, the maximum gland removed is around 40 grams, sir.
No, whether it's a 20 gram, 30 gram, 40, 50 gram, the teaching is that you resect all the way to the capsule. So why is that important? What happens if I don't resect all the way to the capsule?
In recurrence,
Okay, one, agreed, but immediately.
immediately. You may go for increased bleeding actually.
Why? Correct, that answer is correct. That's what I wanted. But why? how does hemostasis occur after you do a TURP? You've done all your hemostasis, but there's still some bleeding. What does the capsule do?
Capsule will be white glistening, sir. Actually,
Anyway, speak louder, please.
His appearance, what
Yes, sir.
does it do? Understand the question.
What does the capsule do to help hemostasis?
Don't know, sir.
So I'll ask a related question before I get the answer. Where should the balloon be dilated, inflated?
Balloon will be in the bladder only, sir.
Why don't I inflate it in the capsule?
The bleeding will be mainly from the bladder neck, sir, not from the. So bladder, if at all we are giving a compression, bladder neck.
No. So what happens for hemostasis is there is capsular contraction. There is muscle in the capsule which contracts, and that sort of pinches off all the vessels coming into the prostate. That is how you have hemostasis, which is why you don't want the balloon in the prostatic fossa to prevent the capsules from contracting.
Yes, sir.
If you had to do an open approach for this patient, how would you manage?
Sir?
If you had to do an open approach for this patient, how
Yes, sir.
would you manage?
One is a transvesical approach, sir, so that we can only enucleation of the nodule can be done.
No, open approach of transvesical, okay? One.
Yes.
Transperineal.
Transperineal retropubic.
Have you seen any of these?
Open prostate.
You've seen? No, I would be surprised if you have seen. If you have not seen, at least the transvesical and the retropubic approaches, please read about it. You don't know when you will need to do it for salvaging your own self. So know about these two procedures.
You didn't scrub on any of the very rare cases. You scrubbed, comrade? No. We haven't done one for some time or the previous batch. Maybe Prasanna's batch and for BPH. No? It must be quite a while since we did one because it's large prostate. 40, that bed fellow, bed fellow 19, scope also wouldn't reach. Fat fellow, man. His son is in America and all that.
Yes.
Oh, then it must be the previous batch. Prasanna and Shivana's batch.
Sir, can I take 10 minutes, sir? I prepared a quiz
Yes.
for you or to training.
You can start.
We'll take 5 minutes. I haven't downloaded. I'll just download it from the mail and quickly play it. Harish can answer the question. We will keep on the slide, whatever options he gives us.
Okay.
2 minutes to load it. In the meantime, Harish, you can continue with the discussion. What techniques of TURP would you be familiar with?
Roger Barnes and Nesbitt techniques.
Okay. So can you tell me the Nesbitt technique?
Nesbitt technique, you have to start from the toe clock position, and you have to first from the grooves, and then resect one part of the gland and go to the other part of the gland.
What is the basic idea in the Nesbitt technique? Why did Nesbitt decide that he wants to cut at 11 o'clock and 1 o'clock, leaving a small sliver, work his way down the other way? Whereas Mr. Roger Barnes did the exact opposite. He started with the middle lobe. So what is the basic idea of Nesbitt doing his technique?
The chips can be.
What was his logic?
Previously, that Roger Barnes was like starting from
What was
the arterial
Nesbitt's
anatomy.
logic? Answer that question first. What is the logic in his technique? Anybody?
Sir, he wanted to tackle the vascularity at 11 and 1 o'clock, and he wanted less bleeding surgery while resecting the glands,
Correct.
lateral lobes.
So he is able to tackle the vessels as it came into the prostate at its source, so that the rest of the prostate falls. Once you resect the top, the attachment to the top is gone. So like the wings of the sail, it comes down. Sails, just come down. And then that part which falls down is absolutely avascular, and you just keep cutting it. All right. The only problem with that technique is it falls over the prostatic urethra and hides the verumentum. So you have to be a little careful as you come working that area. So what is Roger Barnes' idea? What was Roger Barnes' idea?
First resect the down.
Why did he want to resect the middle portion, 6 o'clock all the way down to the veru? There were two reasons for that. One was it would improve the flow. Obstructed prostate, enlarged lobe, middle lobe, all the flow is not good. Remember those days they did not have continuous flow resectors. Alright? So they need good flow. So Roger Barnes said, create a flow. Open the flow route. In many patients, just opening the flow route was sufficient enough for them to pass urine in case there was an emergency. In case you landed up in trouble, you could stop the resection at this point. You've got good control, you haven't done any harakiri, you have not gone to the capsular area where on the sides. You just left this. Some patient gets a cardiac problem, arrhythmia, this, that, anything else. So the other thing was it keeps the because you've got a channel, you've got a hole there. Now the intraprostatic pressure will be low. So therefore, this so-called intravasation into the prostatic veins becomes less.